All right. Hello and welcome everyone to Medical Grand Rounds citywide for today, which is April 17th, 2025. And St. Joseph Healthcare Hamilton is the host site. Next slide, please. All right. My name is Dr. Madeline Verhofstadt, and I'm the Chief of Medicine here. Next slide, please. All right. And we'll start with a land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. All right, go to the next slide. All right, so I'm excited today to welcome our colleague, Dr. Richard Hay, who's a clinical scholar in the Division of Nephrology at McMaster University, who will be speaking with us on the topic of filtering the story on Cystatin C. I'm also excited to have Dr. Christine Ribic co-hosting with me today. Dr. Ribic is the Division Director of Nephrology at McMaster University, and I'm going to hand things over to her to tell us more about our speaker today. All right.
Thank you, Dr. Verhofstadt, and thank you so much for giving us the opportunity to present today on behalf of the Division of Nephrology. I'm very, very excited to introduce Dr. Richard Hay, who you've heard is a clinical scholar within the Division of Nephrology at McMaster University. He completed his medical education and internal medicine training at the University of Ottawa, and then went on to do fellowship training in nephrology and solid organ transplantation here in Hamilton. Dr. Hay has several academic interests, particularly in medical education and curriculum design. And he has a focus in simulation, and in fact is doing a lot of great work right here at St. Joe's and beyond in simulation within our simulation lab. He's currently completing his master's in health sciences education at McMaster, and I'm very pleased to say that he's queued up to join us within the Division of Nephrology on July the 1st. I'm now going to hand it over to Dr. Hay, that's going to tell us everything we would like to know about Cystatin C.
Thank you so much, Dr. Ribic, for the kind introduction, and thank you, Dr. Verhofstadt, for giving me the opportunity to present on this to the Department of Medicine. So I have no conflicts of interest to disclose. So these are the objectives of my talk today. So I will be reviewing the history of Cystatin C and its use in estimating glomerular filtration rate, or GFR. We'll review the recent evidence to support the use of Cystatin C in select populations. We'll discuss some of the barriers to more widespread use of Cystatin C, and then finally talk about a practical approach to the ordering and use of Cystatin C. So for my first objective, just to take a little bit of a step back, so glomerular filtration rate is essentially a measure of kidney function, which is the amount of blood that is being filtered by the glomeruli each minute. Unfortunately, it cannot be readily measured. We've all heard back from medical school the classic example of inulin clearance being the most accurate and reliable way to measure GFR, but it's a very cumbersome and complicated procedure. And so we often use serum endogenous biomarkers to estimate glomerular filtration rate. Some of the key characteristics of an ideal surrogate marker is one that is in constant production, physiologically inert, freely filtered at the glomerulus, not secreted or reabsorbed by the kidney, not metabolized by the kidney so that we can actually see its product in the urine. It also has limited non-renal excretion as well. So we've all heard of creatinine. We use this most commonly as our serum endogenous biomarker for estimating glomerular filtration. It is a degradation product of creatine and phosphocreatine that is primarily stored in the muscle tissue. 95% of this is within muscle tissue. We can also take in creatine through our diet. It's also generated through and synthesized by the liver through amino acids, arginine and glycine, and then methylated into creatine and then stored in the muscle tissue, as I had mentioned. Once it's broken down into creatinine, creatinine is primarily cleared by the kidneys through glomerular filtration. There is limited tubular resorption, but there is some amount of tubular secretion. And then there's also some non-renal elimination through the GI tract as well. But because much of this is dependent on our muscle mass and our body composition, creatinine does have some limitations for its use in estimating GFR. So in the 1980s, people started looking at other potential markers, and that's when cystatin C was first sequenced in terms of its amino acid sequence. It is a low molecular mass protein at 13 kilodaltons. It does have a lot of the key features that we talked about in terms of being an ideal surrogate marker. So it is freely filtered at the glomerulus, with 99% of filtered cystatin C degraded in tubular cells. So unlike creatinine, it is degraded in the tubular cells, so we're not able to measure it in the urine. There is an insignificant amount of peritubular uptake and secretion of cystatin C. Also, unlike creatinine, cystatin C is produced by all human nucleated cells at a stable rate, and it's independent of things like height, age, gender, and body composition. So you can see that there are some differences in its properties compared to creatinine. Some things to note about what can alter cystatin C production and generation, though. Some of the main ones to keep in mind are hypo and hyperthyroidism, certain states of inflammation, smoking, and certain drugs. The most common one that we know about is corticosteroids that can increase the serum concentration of cystatin C. So there's this important concept that we need to keep in mind when we're talking about endogenous markers, and it's the non-GFR determinants of these endogenous markers. So what I mean by non-GFR determinant is anything that can affect creatinine or cystatin C that is not related to the kidney function. So for example, some of the things I talked about with creatinine are when we have extremes of muscle mass. This could be people who are bodybuilders, have muscle wasting diseases or amputations, certain health states like chronic disease, certain things in their diets. We also know about common drugs that can affect tubular secretion of creatinine. And for example, also dialysis we know will eliminate and remove creatinine. So these are all things that we call non-GFR determinants. Cystatin C has, you can see a different set of non-GFR determinants, and sometimes looking at our individual patient population can help us select which marker is most ideal for estimating.
All right.
One, Code White, 4, Bishop Dowling, CTU, room 488, bed 1. Code White, 4, Bishop Dowling, CTU, room 488, bed 1.
Sorry, I am in the hospital, so if there are any overhead calls, I do apologize for that. And then cystatin C, some of the non-GFR determinants are some of the features that I described earlier with regards to extremes of thyroid disease, smoking, steroids, and dialysis. We've also known that there's different equations that have been used to estimate kidney function, and depending on how long you've been practicing medicine, you may be familiar with its use. So in 1976 is when we first came up with the Cockcroft-Gault equation, and some of the reasons why this has started to fall out of favor is that at that time, the measurement of creatinine was not standardized. It also estimated the kidney function looking at urinary creatinine clearance. which we know is not ideal because of the fact that creatinine has tubular secretion in the urine as well. And so this will overestimate glomerular filtration rate, and it's also not validated in many populations. So this has largely fallen out of favor for use in terms of estimating kidney function. But our first modern equation that you've probably heard about before is the modified diet in renal disease equation, which was developed in 1999. This was looking at primarily patients with CKD. So it was a little bit less accurate for patients with normal kidney function. So if your GFR is above 60, it's a little bit more unreliable. But it did measure GFR and compared it to exogenous filtration markers instead of creatinine clearance. So it was a more accurate form of measuring kidney function, but notably, this equation also included race as a coefficient. And then finally, moving on to our most modern types of equations that we've seen are the CKD epi equations that were developed 2009 onwards. So for these equations, they're better estimates of higher levels of GFR because they included larger population studies with healthier patients as well, in a broad range of different levels of kidney function. These studies also looked at measured GFR using exogenous filtration markers like iothalamate clearance, but notably, the original equations also included race as a coefficient. So in 2012, this is when cystatin C was first incorporated in one of our modern adult equations for estimating GFR. And they were able to generate several different equations to estimate GFR using creatinine alone, cystatin C alone, and also a combined equation using both creatinine and cystatin C using least squares linear regression to compare the logs of the creatinine, cystatin C, and also other factors that might affect kidney function.
All right.
So just to show you briefly some of the equations that were generated, you can see the top bracket that I highlighted there are the original CKD epi equations with creatinine alone. And notably, you can see at the end that there's a 1.159 multiplier for if you were Black. So systematically, this would increase all levels of kidney function for Black participants by about 16%. And then we can see that with the cystatin C equation in 2012, there was no race modifier. So cystatin C was not affected significantly by race. We can see that in the 2012 equation when we combine both creatinine and cystatin C, the race modifier still existed, but when combining the two equations together, it was a lower multiplier of 1.08 instead of 1.16. So KDIGO had previously published different criteria for what makes an equation a valid equation. You know, like when we're generating these different estimates of GFR, we know that they are estimates and there's never going to be a perfect equation because, you know, we're looking at big population studies in order to estimate GFR. So what makes an equation valid? So one of these factors is what's called bias or also called systematic error. And that's the absolute difference between the measured GFR and the estimated GFR using one of these equations. There's different values of bias which are considered small. So, you know, if an eGFR calculating equation had a bias of less than 5, we would consider that a small bias. Whereas if you had a bias of greater than 10, that would be considered large and not ideal for a good estimating equation. There's also this other term called accuracy. Sometimes it's denoted as P30, which is essentially estimating the percentage of eGFRs that fall within 30% of the measured GFR. So an optimal equation would ideally have more than 90% of all estimated GFRs fall within 30% of the measured GFR, whereas a poorly performing equation would be less than 80% of all estimates within 30% of the measured GFRs. So just a few important terms to remember as we go through this presentation and talk about some of the different performances of these equations. So this is a graph and depiction of the 2012 CKD epi equations with creatinine alone, cystatin C alone, and then creatinine and cystatin C combined. The yellow bars are the combined equation, the blue bars are the creatinine alone, and the green bars are the cystatin C alone. So on the left, we have bias, and we can see that for basically all measures of kidney function, whether you're at low kidney function or high kidney function, that on average, the combined creatinine cystatin C equation performs better than either of the equations alone. And then when we look at accuracy in particular as well, that the combined creatinine cystatin C equation also has more estimates that fall within 30% of the measured GFR. So that's why at this point, KDIGO had made recommendations that creatinine and cystatin C combined could result in less bias and accuracy if these measures were both available. However, those equations still included race at the time, and in 2020, we had actually for several years, even leading up to 2020, this whole idea of the race inclusion in estimating GFR was highly contentious and was brought forward further through a number of highly profiled racial events that happened around the time that emphasized inequities in healthcare delivery amongst African-American communities. We also had a very poor understanding of how biological factors in race can contribute to increased muscle mass. Also the idea that individuals who identify as mixed racial backgrounds, how would we be applying these equations appropriately in these populations? And also the assertion that race was a social construct rather than a biological one. We can see with all of these different issues, if we're systematically increasing kidney function for African American and Black individuals, that they may have a overestimate of their kidney function and subsequently have decreased access to nephrology care, decreased access to multi-care clinic care, and also decreased access to transplantation.
All right.
So in 2021, this was when we revisited all of these equations and refit them in a way that did not involve race. And so a second set of new equations were generated with creatinine, cystatin C, and the combined equation without race. And I'm just going to show you briefly how some of these equations compared to Black participants and non-Black participants. So we can see that the combined version of the creatinine and cystatin C had a smaller degree of bias compared to either of these markers alone. And then when we look at accuracy as well, so this is measures that fell within 30% of the measured GFR, we can see that over 90% of GFR estimates using both creatinine and cystatin C fell within 30% of the measured GFR, compared to about 85 to 87% when using either of these markers alone. So in the end, the study concluded that the refit CKD epi equation without race, knowing that we're going to be eliminating race as a coefficient, would systematically lower the eGFR of Black individuals and essentially lead to earlier detection of CKD and increase the prevalence and severity of CKD. But keeping in mind that the combined refit equation, when creatinine was used alongside cystatin C, would result in smaller differences in bias amongst all races, along with improved precision and accuracy. So after this study was done and examining these equations, the National Kidney Foundation and the American Society of Nephrology had made several recommendations to eliminate race-based equations, but they also, more importantly, wanted to emphasize the increased efforts to look at newer biomarkers that would not be dependent of race, particularly with cystatin C being one that we've known about for many years, and to encourage more funding and research on GFR estimation without race-based factors.
All right.
So the second objective that I have is to review some of the recent evidence that supports the use of Cystatin C. And so KDIGO has actually published some new guidelines for chronic kidney disease management. And these are 2024 guidelines. And the first one says that in adults who are at risk for CKD, we recommend using creatinine-based EGFR as the initial equation. But if Cystatin C is available, the GFR category should be estimated using the combination of both creatinine and Cystatin C. And then their second recommendation was that the combined equation should be used in clinical situations where the creatinine-based equation is felt to be less accurate, but may also affect clinical decision-making. So one of the things that I wanted to talk about when we stage CKD is, its prediction on outcomes. So this is a graph or depiction that's called a heat map of different categories of CKD that's categorized by their level of kidney function and also by their level of proteinuria at the top. So the table on the left is the heat map for staging CKD when creatinine alone is used, whereas the table on the right is the heat map for all-cause mortality when the combined creatinine and Cystatin C equation is used. And I just wanted to highlight one of these boxes so that you can see some of the significances. But when creatinine alone is used to estimate and stage chronic kidney disease, we see that there's a hazard ratio of 1.3 for all-cause mortality. Whereas when we're using both creatinine and Cystatin C, that we see a much more significant signal that with a hazard ratio of 1.7 for all-cause mortality, indicating that perhaps there's more clinical meaning and endpoints when we use the combined equation. Similarly, these are two tables. So these are two graphs. The one on the left is when we look at GFR estimates with creatinine alone, and the one on the right is with GFR estimates using both creatinine and Cystatin C. And several different causes of mortality, including cardiovascular mortality, all-cause hospitalization, myocardial infarction, stroke, and various cardiovascular events. Their hazard ratios were plotted against their EGFRs. And you can see that when creatinine and Cystatin C are combined, that we have steeper curves for these hazard ratios and different endpoints. And then another interesting thing to highlight is that on the left, where creatinine alone is used, we also have an increased hazard ratio when the kidney function is above 105, which points towards the idea that perhaps there's something else going on. It doesn't make particular sense that people with extremely high levels of kidney function are having higher mortality than people with lower levels of kidney function, but perhaps this is signaling that people with a very low creatinine perhaps have lower muscle mass and other reasons to have chronic illness and sarcopenia that is leading to increased mortality. And then interestingly, when we look at the combined equation with creatinine and Cystatin C, this effect is essentially eliminated.
All right. All right. All right.
So when we compare the different equations with creatinine and Cystatin C, there's this concept of concordance versus discordance. So we know that with large population-based studies, when we've looked at all comers and estimating their GFRs with creatinine and Cystatin C, about 25 to 30% of them actually have a discordance of more than 15 mils per minute. However, if there's concordance, so if the EGFR by creatinine and Cystatin C, they are within 15 mils per minute, and they all line up with each other, we know that the accuracy of the combined equation is as high as 87 to 91%. However, if there is discordance between the two equations, we know that combining these two factors is more accurate than using either equation alone for the general population.
All right.
So what are some clinical areas where we might think about needing more accuracy in estimating GFR? So your classic example that you might think of is the bodybuilder, the one that's participating in extreme sport, because these people have extremes of muscle mass, and perhaps they may not have an accurate reflection of their estimated GFR when you use creatinine alone. Similar to this, on the other end of the spectrum, people with eating disorders, above knee amputations, people with spinal cord injuries and paraplegia, they might be at significant risk for muscle wasting, and perhaps the opposite effect might take place.
All right.
When we want to think about extremes of muscle mass, we should also think about specific populations of chronic disease and illness. And one of these that have been particularly of interest and studied over the last few years is in oncology patients. So we know that oncology patients in general, they're more susceptible to the non-determinants of GFR. We also know that there's a higher prevalence of CKD in this population, up to 32%. And we also know that GFR or estimating GFR is very important for this population because it may make them eligible for certain clinical trials, certain targets and cutoffs for therapeutic and systemic therapies, and also predicting potential drug toxicity. So this is the population that is particularly susceptible to having discordances in their GFRs, yet we know that it's very important to accurately estimate their kidney function because they're at risk for sarcopenia. This is a study that looked at estimating GFR called the OncoGFR study, published a couple of years ago, and it looked at 1,200 participants with solid tumors. The section that I highlighted there is looking at the different measures of bias and accuracy when creatinine alone was used. So you can see that there's quite a significant bias of 8.1 mils per minute when creatinine alone was used to estimate kidney function. And then also the accuracy, they reported as 1 minus the p30, which means that 19% of all participants fell outside of 30% of their measured GFR when using the creatinine-based equation. However, when we use both creatinine and cystatin C, we can see a significant reduction in the bias from 8 mils per minute to 2 mils per minute, and also a significant improvement in the accuracy as well, with only 7.8% of individuals falling outside of 30% of the measured GFR, compared to 19% when using creatinine alone.
All right.
This is a table that I just wanted to put in to highlight. You don't have to know these drugs obviously in detail, but it's a table of different systemic therapies that are offered for various oncology populations. And the point of this slide is to see that for people of varying kidney functions, they may be eligible for full doses, dose reductions, and sometimes even contraindications when their dose falls below a certain amount. So this really shows the importance of accurate estimations of kidney function, because if we're talking about a bias of 8 mils per minute in the oncology population, but there's going to be a significant difference in drug dosing when you can be a couple mils per minute off of the what would make you eligible for certain therapies. That is what makes this a truly important area for making a more accurate estimation of kidney function. This is another interesting study that looked at creatinine-based GFR and cystatin C-based GFR whenever there was discordance identified in an oncology population. So the dark blue bars are when the eGFR using creatinine is significantly higher than the eGFR based by cystatin C. Whereas the other two bars represent when they're either concordant or when the cystatin C-based estimate is higher than the creatinine-based estimate. You can see that for patients who were treated with vancomycin, there were significantly higher trough levels in the toxicity range above 20, 30, and 40 for patients when their creatinine-based eGFR overestimated or were discordant from the cystatin C-based estimates. This same study looked at some other common drugs as well, and we can see that when baclofen was used, there was also significantly higher rates of side effects with altered mental status, up to 15% in orthostatic hypotension, whereas those with concordant GFR, or when the cystatin C was higher than the creatinine-based GFR, there were actually no patients who had these side effects. And then the same with digoxin toxicity.
All right.
So as a result of a lot of these studies in the onconephrology population, there's actually been a statement made by the American Society of Onconephrology that had stated that clinicians should be aware of some of the shortcomings of creatinine-based equations, and if possible, use validated GFR estimating equations incorporating both creatinine and cystatin C for decision-making related to anti-cancer therapy for eligibility and dose adjustment. And then another statement saying that in patients receiving anti-cancer drugs that can cause inhibition of tubular secretion of creatinine, those are some examples there, who experience an increase in creatinine should consider measured GFR using exogenous filtration markers or non-creatinine-based estimates prior to discontinuation or dose adjustment of these agents. Another population to keep in mind is our hospitalized patients with respect to drug dosing. So this was a study that looked at 17,000 hospitalized patients who had discrepancies between their EGFRs by creatinine with an average EGFR of 65 mils per minute. But the EGFR using the cystatin C equation was 46 mils per minute. So there was a median absolute difference of 15 mils per minute between these two equations, and 45% of participants had a greater than 30% discordance between EGFR using the two different equations. Why is this important? Well, we know that a lot of the drugs that we dose in hospital are going to be according to different levels of kidney function. And we've actually seen that a systematic review that was published in 2020 looked at several different drug dosing studies when cystatin C was used as a marker of clearance. Cystatin C actually better predicted drug clearance compared to creatinine C for the majority of drugs that were studied. And largely, this is in antibiotics, and the most robust data that we have here is with vancomycin, but also other drugs have been studied, including beta-lactam, some anticoagulants, and some systemic therapies for cancer patients as well. However, we do need to be cautious about widely dose adjusting patients in hospital using new formulae because we may be underdosing our patients if we're going to be systematically using a different equation, and of course we would need individual drug studies to ensure that they're safe with using new estimates of GFR. Another thing to just keep in mind that there's several chronic illnesses that have been looked at in addition to cancer patients. We know that when cystatin C is used, there's also a consistently smaller bias and higher accuracy in estimating GFR in HIV patients and also in obese patients. The accuracy and degree of bias is a little bit less clear for other chronic illnesses such as heart failure, cirrhosis, transplant patients, critical illness, and neuromuscular disease. But a lot of this is also due to the fact that these studies are much smaller and perhaps we don't have as much robust data in these populations. I highlighted heart failure and cirrhosis in particular because of certain areas where we may be considering dual transplant for heart kidney and liver kidney, where we'll have different cutoffs for kidney function, where we would consider a dual kidney transplant. But if we're not accurately able to estimate their kidney function, then that may either exclude or include a large number of patients who are being considered for these dual transplants. So my next objective is to talk about some of the barriers to widespread use of cystatin C. So I hopefully have shown you some literature and evidence to highlight why I think the use of cystatin C is really important, but why isn't it used more often? So first, I wanted to talk about maybe some of our local experience and access to cystatin C use. So in terms of access to testing at St. Joe's and at HHS, there is an increased cost of ordering a Cystatin C compared to ordering a creatinine. So we know that it's about $30 or so to send off a Cystatin C, whereas it's less than $1 to send off a creatinine. And the current process includes needing to call the biochemist on call and needing approval. I've done this a few times, and sometimes, it's not readily available and takes a little bit of work. So that might be a bit of a deterrent in terms of access to testing. The other thing to note is that testing is actually not available in-house. And whenever we order a Cystatin C here, it's actually shipped off to Ottawa and performed at CHEO, the Children's Hospital in Ottawa. So there's a significant turnaround time of 8 days, which might also deter people from ordering a Cystatin C, especially if you're ordering one in an inpatient setting and you're getting a Cystatin C back 8 days later. You're probably not going to be able to do much with this result if you're getting it back a week later. And then I've also spoken with the biochemists here, and apparently in the past year or annually, there's approximately under 100 Cystatin C tests that are ordered at St. Joe's and HHS every year. Cystatin C is also available to be ordered in some private labs for a fee. So I actually called some private labs as well to see what the cost is for a patient who would have to pay out of pocket, and it would be about $60 for them, and they would be able to produce a result and turnaround time within 24 hours, which is much better than the 8 days that we would need here in hospital.
All right.
However, what are some of the barriers to Cystatin C implementation in-house if we wanted to order it? So, of course, it would be great if we just said we wanted to develop have the ability to order a new test and be able to order it and have the turnaround time within the next day. But there's going to be costs associated with whenever a new lab test is introduced, including analyzers that might need to be purchased, training staff, being able to buy new reagents, assessing performance of a test, and maintaining performance of this test. There's also concerns about overutilization if the test is not ordered appropriately. So I highlighted earlier that there's certainly advantages to ordering Cystatin C within certain populations in estimating GFR, but perhaps if your kidney function was completely normal and there were no reasons to have an accurate level of kidney function, it would certainly be much more expensive to order Cystatin Cs every time we ordered a creatinine. And then, like many issues in our healthcare system, just an overall lack of funding. If we were to think about implementing the ability to perform Cystatin C testing in-house, one of the most important things is the idea of clinician championing. So basically being able to gather bodies of evidence based off of clinical utility, some of which I've done as part of this presentation, but also have a lot of buy-in from clinicians who will think that this test will be useful. And also part of that is developing guidelines on how we think this test should be ordered and who should be ordering this test. Once we have that type of guideline and evidence gathered, then it's a matter of approaching the biochemistry lab to evaluate things like the equipment needed, reagents, training, and also cost effectiveness of being able to implement a new test like this.
All right.
So I looked at some data in some Canadian centers. So there was a study published in 2017 with the London Health Sciences Centre. So this was a cost-effective analysis that they looked at 8 years ago. And at that time, it cost them $25 per test to send out a Cystatin C to CHEO, compared to only $7.30 if they were to perform the test in-house. And they calculated that if they ordered 2,000 tests per year, that this would actually save $35,000 per year being able to implement this test in-house instead of sending it out. So if we were to think about doing local implementation, similar type of cost analysis and estimates of its use would need to be made to make a case for the ability to order Cystatin C. But just comparing to other centers, thinking about our patient demographic, our catchment area. Certainly, if London was able to successfully implement this test, with Hamilton being a larger center, it's certainly something that we could consider, and certainly the volume of testing would be there. I think part of the reason why so few tests are being ordered in Hamilton is, like I mentioned earlier, the accessibility and the turnaround time of these tests.
All right.
And then other challenges in implementation that we may want to think about is that even though a single test, you might think $30 is not that expensive if you were to order a single test. If we implemented this over a large health system, with the example that I used, if every creatinine came along with a Cystatin C, that instead of $1 for estimating GFR, now it's going to be $30. Certainly that would have a significant impact in costs over a large health system. And then other things to think about are who should be able to order the test. Should it be restricted to nephrologists? Should it be pre-specified patients meeting specific inclusion criteria? For example, like I mentioned earlier in the cancer population, for some of the reasons that I discussed. And then we also have to think about the risks of indiscriminate ordering and what the impact that this might have on costs.
All right. All right. All right. All right.
Finally, I wanted to discuss just a bit of a practical approach to the ordering and use of Cystatin C. So these were some guidelines and tables that were provided by KDIGO. So I think as an initial test, it's always reasonable to think about using creatinine as an initial test for estimating GFR, using one of the validated equations that we talked about. But you'll want to consider sources of error and also the need for more clinical accuracy. Is this going to be something that is going to affect patient eligibility for certain trials or drugs, and some of the risks, some of the different factors that can affect creatinine? So, if it's thought that a more accurate estimate of GFR is necessary, then this might be an indication to measure the Cystatin C. And then finally, you also want to think about potential sources of error in eGFR equations using both creatinine and Cystatin C. And if there's a need for even more accurate measurement, you may want to do a measured GFR using one of the exogenous markers of testing to better accurately measure GFR. Some of the indications that I've sprinkled at points throughout the presentation, but you definitely want to think about patients with large variations of body habitus and muscle mass. So those include things like eating disorders, extreme bodybuilders, amputees, people with spinal cord injuries, people with varying diets that are either high or low in protein. You also want to think about things like chronic illness, malnutrition, sarcopenia, people who are in hospital for various other reasons and resulting in muscle wasting. And then you also want to think about medication side effects whenever you're taking medications that might cause increased secretion of creatinine, and realizing the impact that might have on estimating GFR. And that all comes down to, as I mentioned in the beginning of this presentation, this idea of the non-determinants of GFR in creatinine and Cystatin C. And although they're different, they do complement each other because they tend to have different gaps in when they're more or less accurate. So you'll always want to think about these non-determinants of GFR whenever ordering a test to estimate kidney function. So in conclusion, Cystatin C is a guideline recommended lab test for estimating GFR for patients at risk of CKD and in clinical scenarios where creatinine is less accurate. There continues to be barriers in implementation and use of Cystatin C, and requires further clinician championing for more widespread access. And I think that St. Joe's and Hamilton Health Sciences would likely benefit from the ability to perform in-house Cystatin C testing, given the diverse populations that it serves, but of course requires further analysis from a laboratory perspective.
All right.
So that is all I have. So I would love to hear any questions, personal thoughts. If you have personally ordered Cystatin Cs before and your experiences and where you might think, it would be helpful.
All right. All right. All right.
Thank you so much, Dr. Hay, for an extraordinarily clear and thorough review of this very interesting and important topic. I personally learned a lot, and I'm excited to hear from our audience now with that kind invitation of thoughts, experiences, and questions. I do see that Dr. Ann Holbrook, I believe, has a hand up, so I'm just going to ensure that you can unmute your mic, Dr. Holbrook.
Yeah, there we are. Thank you, Richard. That was excellent. Really an excellent summary. So I have a two-part question. If we take, as we should, this is very relevant to clinical pharmacology to begin with. So really a nice summary, and I learned a lot as well. But if we take our typical evidence-based approach, I'm putting on my health technology assessment here, we would ask, as the final stage, show us the randomized trials where using cystatin instead of, creatinine really made a difference in outcomes. One of the reasons we tolerated the chaotic way that troponins kept changing was that PJ kept coming up with, very good evidence that, the next generation was actually better in determining outcomes. So I would say that's what this needs. And I don't think I heard that. So if you could comment on that. Because my next part B is the areas that the guidelines are suggesting virtually every patient I see. That does not help me differentiate, and probably just about every patient you see. So the second part is, even without that sort of clinching evidence, who do you think really are the priority patients that should have this done instead of or in addition to creatinine-based testing?
All right.
Thank you so much, Dr. Holbrook, for those questions. So for the first part of your question, yes, I agree that, we're certainly lacking some of the randomized control trial data. Actually, basically all the data that I presented were observational data, just based off of the nature that we've been able to collect kidney function estimates in these different populations. And I think it really matters when, outcomes are impacted. And although we don't have the RCT data, some of the evidence that I highlighted, for example, that certain populations like cancer patients who we know that are highly at risk, for example, having much more drug toxicities and much more drug side effects. I think certainly that, is an area where outcomes are really matter. I think even with, some of the pharmacology and drug dosing, and I'm not an expert at this, of course, but, there is certainly some robust data for drug dosing for some drugs, particularly I think vancomycin is the one that's been most well studied using Cystatin C and getting accurate trough levels compared to creatinine. So those are maybe some areas that I agree need further look in research. And then I guess the second part of your question, for sure, like basically everyone that in hospital is going to be at risk of muscle wasting and discrepancies in kidney function estimates. I guess something to think about is what medications are we ordering for some of these patients at risk? Are there medications where the estimation of GFR is going to make a big difference in their their outcomes? And I think the oncology population is probably a very good example, and probably the most robustly studied, just overall in terms of access to clinical trials, access to systemic therapies, and also very narrow windows of what eligibilities for drugs and contraindications to drugs they may have. So I think certainly there's more area of research in Cystatin C.
All right.
And then I think Dr. Holbrook, did you have a follow-up portion there?
All right.
No, I'm fine. Thank you.
Okay, perfect. Thank you so much, Dr. Hay. I'll hand it over to Dr. Ribbit.
All right.
Thanks so much, Richard, for that very comprehensive review. And it's great that you had the opportunity to speak to our biochemists as well in the laboratory. Some of the questions I guess I had were similar to what Dr. Holbrook asked. but also maybe just digging into a little bit deeper about, when cystatin C might be misinterpreted. So you've outlined perhaps the patients where we might consider using it. But there are a lot of factors. You touched upon medications that can interfere with cystatin C measurement. But when do you think that cystatin C may not be the best marker in terms of renal function, and in what population should we really hesitate in using it?
Thanks so much, Dr. Rubik, for the question. So I would say the ones that have been most well studied in the literature are those with extremes of hypo and hyperthyroidism. So particularly with patients who need treatment for hypo or hyperthyroidism, cystatin C is lower in patients who are hypothyroid and higher in patients who are hyperthyroid. And you can think about it as the more active and hyperactive you are, it causes more metabolism and turnover of cells. So that would certainly be an area of caution. And then I think steroid use is one of the other areas of caution. So for example, I believe in transplant patients, there's not great data to use it because most of our transplant patients are on chronic steroids. And there's not really a great guidance on what level of steroid is and how much it's going to alter the estimated kidney function. And similar to thyroid disease, it would also cause a higher turnover of cells and increase in cystatin C in those patients.
All right.
Yeah, the nice thing I think is that the non-determinants of GFR in creatinine and cystatin C are different and complementary. So that, if they were the same, then there's no purpose of one test over the other. But the fact that they're different and complementary, I think there's certainly areas where we can use those non-determinants of GFR to our advantage.
All right.
Excellent. Thank you so much. Thank you for that question, Dr. Rubik, and for your response, Dr. Hay. So I think if there aren't any other comments or questions from the audience, we can once again thank our presenter today for all the excellent work in preparing an extremely comprehensive review of this topic. So thank you very much, Dr. Hay. And thank you all for attending, and Dr. Rubik for co-chairing with me, as it were. We will be back for Citywide Medical Grand Rounds next week at the same time. It will be HHS Teaching Medical Resident Rounds next week, followed on May 1st by Chairs Medical Grand Rounds. So please keep an eye on your inboxes for further details and registration info. And have an excellent rest of your day and leading into a long weekend for most folks. Thanks again. Take care.
Thank you, everyone.